Good evening, everybody. Thank you for joining. For those of you that don't know me, I'm Tracy Milgram Posner, the founder of Practice Strong, where we educate, inspire, empower, and advocate providers, survivors, and thrivers to eliminate the feeling of isolation. You do not have to carry the BRCA to be part of Practice Strong. We're here to support everybody. Our goal is to fund women post-mastectomy garments and help you feel whole again. We do this by transformational photo shoots, fashion shows, getting women together, and just feeling like a community. During COVID-19, we're sending out care packages to women who are in our local communities or national, just letting them know that they're not alone. So if you're a family member, need anything, you can feel free to reach out to myself or Kate, and we'd be more than happy to help you. Tonight, we have a special guest, genetics and breast cancer, Dr. Negron. Thank you so much for coming on and dedicating your time to educating our community, especially during COVID-19. Bringing physicians on has truly helped us and helped our women who don't have access in different areas or don't have access to their physicians. So thank you again for coming back on to Practice Strong. We love having you and all that you do for the community.
Thank you for the invitation. So let me see if I know how to do this. So I will be sharing, and it will be this. Can you see this?
Yes.
Okay, perfect. Okay. So I'm Dr. Martir-Negron. I go more by Martir. Martir is my father's last name, and Negron is my mother's maiden name. I'm the medical director of the Division of Clinical Genetics at Miami Cancer Institute. When we talk about the cancer risk, the majority is the environment, lifestyle, family history, but you know, there is a percentage, and it will be like around 15% that is associated with being born with a predisposition. What is genetics? So we're made of 20,000 genes, way less than we thought back in the 90s. And approximately 80 genes, and I will say that this is growing. Now it's like 91. I test for 91 genes depending on the panel of genes associated with hereditary cancer. Cancer genes, when working properly, protect us against cancer. So when somebody said, it's incorrect when somebody said, I have the gene. No, it's I have a defect, a mutation, a change in the gene, because these are tumor suppressor genes in the 99% of the cases, and you want to have them, but working properly, working for you. And our genes come in pairs, one comes from mom and one from dad. In general, when we think about cancer, this is in general, would be ages younger than 50, multiple primary cancers in one individual, multiple close family members with cancer in the same family lineage, rare cancer, depending on the ethnicity. For example, Ashkenazi Jewish, for BRCA mutation, it's 1 in 40, but there are other ethnicities in that they are in an increased risk. For example, people from Bahamas has an increased risk for BRCA mutations too. And then specific combinations in the family. If you see, for example, breast, ovarian, breast, pancreatic cancer, breast, colon cancer, then we need to look in these syndromes. Specifically for hereditary breast cancer, is early onset of breast cancer. This is when to get to see the doctor. It's usually less than 45 or less for the age. But then as you look at for example, if it's bilateral, so if you have a bilateral presentation, we say this is that you have 2 cancers. So, and the guideline said if one is younger than 50, that is enough. If you have 3 family members with breast cancer, the age doesn't matter. If you have a first or a second degree with male breast cancer, and also we said first and second degree, but for example, if you have a 3rd degree family member, but your parents are not alive or they don't want to have genetic testing, you can say that you have somebody who meets criteria but is not available for testing. So testing is becoming easier and also less expensive, so that makes it more affordable, that makes it more accessible. Family history of 3 or more cases over 2 more generations, triple negative. So triple negative, if you're 60 or younger, that will be enough to recommend genetic testing. Triple negative you see in BRCA1, and there is a suspicion that it's in another 3 genes that are gonna show you later. The Ashkenazi Jewish ancestry, like I said, BRCA1 and BRCA2, 1 in 40 versus 1 in 400 in the non-Ashkenazi Jewish population. A history of breast and ovarian cancer in the same individual, and a specific association with primary cancer, like I said, breast, ovarian, breast, endometrial, thyroid, lobular, and stomach. And I'm gonna be discussing this later. So what genetic testing can tell you, because I think that some people think so, they expect so much from genetic testing, and really there's so many, it can give us a lot of information, but also in many cases, in the majority of cases, doesn't give us any answer. So it can tell you the cause of the cancer diagnosis, or it can, at least you can say it's likely associated, because sometimes you have a mutation in a gene that the risk for the particular cancer that you have is very low. Then you say maybe there is something else that contributed to that cancer. Risk for a new breast cancer diagnosis. So for example, when somebody has a mutation in BRCA1 and they develop cancer, the risk for a second breast cancer is approximately 47%. The risk for a second breast cancer in BRCA2 is approximately 27. No, I'm sorry, it's 40% in BRCA1, the risk for a second breast cancer, and 27 in BRCA2, the risk for a second breast cancer. And in general, if you carry a mutation, it's expected to be increased, but for many of the genes, we don't have the numbers. Risk of developing other cancers. So we can give you what is the risk in terms of percentage of developing other cancers, and risk for family members, and also the risk for family members to increase the inherited, risk for family members to inherit an increased risk. Also, when you give the risk, you also can give recommendations. What it doesn't tell you is information about the current state of health or disease. So if you're tested, it doesn't tell me what is the, it doesn't tell me what is your recurrence risk, for example, or if you have cancer at the moment of the diagnosis. It will not tell me if you will develop cancer or not. A new cancer, it could be a new breast, another breast cancer, it could be any cancer. It can give us like an idea in terms of risk, but it cannot tell me for sure. Risk of current cancer to come back of metastasize. So many times when I see a patient, they said, I want the genetic testing because I want to know what is the risk for this to come back. And no, I always say, the risk of coming back is depend of how aggressive is the cancer, how good was the treatment. This is a fight between the team and the cancer, and you have all the treatment, but sometimes you can come back. But it doesn't tell me what is that risk. And the side of the family where the risk is inherited from. So we need to do testing in parents to know. If parents are not available, we start testing each side of the family until we find a mutation and we can know where it came from. And the risk for other things such as heart disease, diabetes, or Alzheimer's, these cancer panels, it can give you a little, even though it's not there, the cancer panel also include pancreatitis genes. It's not cancer, but because pancreatitis can increase the risk for cancer, we can test for that. We can test for colon polyps. It's not cancer, but because it increases the risk, we can we can then give you recommendations, but not for these other diseases. So when you do genetic testing, there is 3 possible results: positive, negative, and inconclusive. The most common is negative by far, because like I said, 15% of the cancers in general are associated with a predisposition. So in the majority of cases, the patient doesn't carry a mutation. What you do is you manage based on personal and family history of cancer. So if you come because you have your mother had breast cancer and you test negative, we do a calculation of risk using statistical models to tell you what is the risk of you developing breast cancer and what will be the recommendation in general when we test somebody whose mother or a sister had breast cancer, first-degree family member or daughter. The risk is usually more than 20%, so they get the increased screening, high-risk breast cancer screening with mammograms and MRI. If somebody, for example, has 2 family members with ovarian cancer, a first and a second-degree family member, and we don't have explanation for those ovarian cancer, and they test negative, we still recommend the removal of the ovaries because we don't know what caused, and it's not a good. We cannot screen well. The same for ovarian of uncertain significance. So what is ovarian of uncertain significance? So for that, we need to know what is the purpose of what the DNA does. So the DNA, what we test, the gene, the DNA has the information. So the gene has the information to make a protein. It's like a recipe. So if the recipe is working well, then that protein is formed, and that protein. So the way that the function happens is because of a protein, but it's not a protein that you can take. It's a protein that is only made by this gene. So if there is if we have a change in that recipe and the protein cannot be formed well, then that protection is not there and cancer may happen. If, on the contrary, everything looks fine, so the protection is there, that doesn't mean that you will not develop cancer, but then you either have the risk based on family history or you have the average risk. Then the third is the inconclusive, and the inconclusive, what it means is that you have a change in the recipe, but we don't know if that recipe will make or not the protein because we haven't seen it in enough people with the cancers associated to it. So for that, we need for more information that accumulate. And I'm talking a lot about this because inconclusive are the same as negative until proven otherwise. And I have cases, which is cases in the scientific literature, and also that I know that people have done clinical surgical decision making for an inconclusive, which in 90% of the cases are nothing, are benign changes. And it's because we all humans share 99.9% of genetic information. So these changes that we have make us who we are. So remember, inconclusive is negative until proven otherwise. You don't do anything about this other than to look at the family history and calculate risk. So Tracy asked me to talk about the different type of genes associated with breast cancer, and I'm gonna go over that. So the general population risk of developing breast cancer is approximately 12.8%. Now they're saying 12.8. So it's almost 13%. And the familial risk is when we do that calculation, and we found it's usually between 20 to 30%. And the moderately risk genes is this 30 to 50%. That's ATN, CHEK2, CDH1. And then the high-risk genes are BRCA1, BRCA2, TP53, PALB2, and I'm gonna show you. So for this, the population risk, you do your regular mammogram. For all these, there is the recommendation of having high-risk screening with mammograms and MRI. And for this in the top, there is the recommendation of the high-risk screening or the removal of the breast prophylactically, or if you have cancer, the other breast. So this is, I need water. So I took a picture. This is from a lab. This is the genes associated with breast cancer that are in guidelines, except, oh my God, what I did, hold on. Except for MRE11A, and I'm gonna discuss this, and RAD50, the others are in guidelines. This group in the top are the ones that we send for testing. So until here, on TP53, this is when we do high risk breast cancer. So we want to have the information for your doctor for surgical decision making. This is the one that we test, but that doesn't mean that these are all the genes we recommend removal of the ovaries. I'm sorry, of the breast. So BRCA1, BRCA2, PALB2, and TP53 are the ones, only the 4 genes that are in guidance. Because the risks of these are well known and is expected to cause cancer in the other breast, even though we don't know what is the risk for the second breast cancer. This is why it's part of the surgical decision panel. Then this other here, for example, BART1, there is a recommendation for screening. And then I have this BRIT1, RAD51C and 51D. I want you to look at the BART1, RAD51B, and RAD51C. So I mentioned to you that there are some genes associated with breast cancer that are believed to be associated with triple negative breast cancer, and is these 3. So this BRIT1, RAD51C, RAD51B, we know for sure is associated with ovarian cancer. It's recommended to have the ovaries removed. For many years, there was no information regarding the breast cancer genes. And since 2019 or the end of 2018, they started to mention in the guidelines that there is a possible risk for breast cancer. And then last year they said possible risk for, they call it potential, increased risk for ovarian cancer, for breast cancer, but now they mention for breast cancer triple negative. But they still we don't have recommendations for high-risk screening for these patients. MRE11A is not an MUTYH, even though they're believed to be associated, we don't have recommendations. The NBN, there is a recommendation for increased screening with mammograms and MRI. NF1, there is also a recommendation for mammograms and MRI, but it's because the risk is 20%. But this is associated with physical fissures. This is neurofibromatosis type 1. Patients have multiple, usually benign tumors in the skin, and also there are tumors, plexiform neuromas, that can grow inside and can cause a lot of problems. They're they grow in the neurons, so it's in the, you see it's in the spine also, and the patient has freckling, and usually by the age of 5, somebody can know that they carry a mutation. They have multiple Kaffel spots, and by age 5 we know. So many of the patients that come to see us that we test, they know that they have NF1, or they have not been diagnosed, but I can see and say you have it. Let me show you the other, because it's okay. So these are the candidate genes: BLN, FAMC, and XRCC2. Just so you know, these are most commonly in the Ashkenazi Jewish population. RAD50, I think that the guidelines are pending. Hopefully it's gonna be soon. And for all these genes that are candidate genes, what it means is that we believe they're associated with breast cancer, but there is not enough data. There is data about if somebody carries 2 mutations of this is Bloom syndrome, which is short stature, hypersensitivity to light, and a lot of risk for cancer, and they may have intellectual disability. Fancy's Fanconi anemia, when you carry 2 mutations, that increases the risk that for leukemias, and patients with intellectual disability, they have bone deformities. And these candidate genes, what it means is, for example, if somebody carries a mutation in this, I say, you know, there is no recommendation. We look at the family history, we do calculation of risk, and we tell the patient, you will be first in line when this get into the guidelines, and we see these patients once a year. So I want to go over each of these. BRCA1, everybody, well, not everybody, but the majority in the audience will know about this. This is an overcalculation. It's not 87, it's more 70%. The MRI is from age 25 to 29. The risk-reducing mastectomy is recommended. And I mentioned these are, PTEN is also a gene that is recommended, or I would say it's considered. It's a consideration. And then there is an increased risk for a second breast cancer for this, and it's associated with ovarian, pancreatic, prostate, and melanoma. PTEN, this is associated with enlarged head circumference. So when you go to the genetic clinic and they measure your head, is because PTEN is associated with that. PTEN is also associated with endometrial cancer, thyroid cancer, kidney cancer, colorectal, melanoma not so much, but it's believed to be associated. It's not here, but it's associated with autism too. TP53, this is associated with basically any cancer, you name it, but ovarian cancer. The risk is very high. These patients have risk for cancers in any part of the body, but the ovaries. And the screening is a whole body MRI for these patients. This is the most difficult cancer, cancer predisposition syndrome is this one. CDH1 is one of the most difficult to counsel because some of the recommendations. So this is associated with lobular. So you hear a lot about invasive ductal carcinoma, which is the most common, or you hear about DCIS with ductal carcinoma in situ. But the lobular is a different subset of cancer, and in histology, the doctor will tell you. The risk-reducing mastectomy, and for all these genes where there is no recommendation to remove the other breast prophylactically, or to even to do it before developing cancer. A lot has to do with look at the family history, see how is the family history, and then the discussion with the surgeon. What is bad about this is this is associated with diffuse gastric carcinoma. And the problem is that in the diffuse, when the doctor is gonna do the endoscopy, when you think about cancer, you think about that there's gonna be a mass, right? And if there is a mass, it's removed and that's it, or, it's removed and they check, but you can visualize and you can treat it maybe early if it's tiny. But with the diffuse, it's just grow to the inside and to the side. So you don't see a mass. And then when the doctor is looking, if you try to do screening, it's difficult to see, and the doctor has to, just go and look and take some samples. And studies have demonstrated that even though the sample can come back negative, the majority of patients already had cancer. Even though, so they did a study that people who decided to remove the stomach, because that is the recommendation. This is why I said it's difficult to cancel. So you say when people knew that they will do, they decided to remove the stomach. They before that they did this blind biopsies, and in 99% of the cases, the biopsies were negative. The blind biopsies, the screening, but the 99% of the cases had cancer already. So this is why this is very, very difficult to counsel. PALB2, that is associated with, you'll also look at the family history. This is associated with pancreatic cancer. This is also associated, this is associated with, like I said, pancreatic cancer, mainly breast cancer. And then STK11 In this one, it's very rare, and the patients, the main cancer is usually colon cancer because the patient has polyps. But in this, and pancreatic cancer is also part, but in this one, the patients, especially when they're children, they have hyperpigmentation of the mucosa inside the mouth and in the lips, like a lot. But then as they grow, that faint a little bit. But then they usually has a family history of people dying of colon cancer. And then when you ask for pictures or see the patient, you notice the hyperpigmentation. So there is physical features. Like with P10, there is physical features for this one too. ATM. ATM is associated with breast cancer. And so this is an old slide. So I apologize. It's not potential risk anymore. It's associated with ovarian. I'm sorry, my bad. Yeah, it's associated with potential risk for ovarian cancer, but it's definitely associated with prostate cancer, pancreatic cancer. Not so sure. So insufficient evidence. The I is insufficient evidence, but this changed. Now pancreatic cancer is definitely part of this syndrome, and there is the recommendation for screening. Prostate cancer is still not part of the syndrome. SHEC2 is associated with breast cancer and colorectal cancer. So the recommendation is if you carry a mutation, to have colonoscopies starting at the age of 40, no more than 5 years. NBN, in this they changed there is no recommendation for reducing mastectomy. There is recommendation for high risk screening. And then NF1, I mentioned already, is associated with malignant peripheral nerve tumors. This GC is gastrointestinal stromal tumor. And the NF1 is the one with that I mentioned that has a lot of physical features. And by age 5, you can make the diagnosis. So BART1 and MRE11 BART1 is associated with ovarian cancer. I mentioned a possible triple negative breast cancer, and MRE11, there is not enough data. So this is another way to look into this. So BRCA1 and BRCA2 by far is the one with the highest risk on P10. And this is the one that the consideration of removal of the breast prophylactically. TP53 is missing here. And then we have the risk for the others that is usually between 30 to 50%. And I always mention to the patients that the TP53, the range of I was mentioning 30 to 50%. So the range is so wide because it wasn't until 2013, 2014 that we started to test for this year. So we don't have the population database to know exactly what is the range, but it's definitely the risk is increased. So, and I was mentioning for some is screening, for some is surgery, and this is for the high risk. The moderate increased risk is based on family history. Something that you need to consider is life expectancy when you're talking about surgery, and how much risk is left. So if somebody is 75, 80 years old, would you recommend surgery? Not necessarily, because that person is even past of the data that we have this calculation of what is the risk when we give percentage. It's usually until the age of 76. And also you have to see not only the life expectancy, but also to see if there is any comorbidity. The combination of mammograms and MRI alternate every 6 months is good. But I always mention to the patients that this is more early detection, and this is doing the most the humanly possible to make sure that you don't develop, but the risk is not removing the breast doesn't mean that you will never develop breast cancer. It means that your risk is close to zero, but it's not, and you still have to have screening. And this is a case, I don't know if you heard Nina Garcia, she's from Project Runway, and this is not for everybody, but she was diagnosed with BART1 and she talked about it. So it's always good when somebody mentioned that there is other genes associated with breast cancer. For BART1, she decided to have her breast removed because of the many issues that she has due to many biopsies, but there is not a recommendation for BART1 to remove the breast. There is only recommendations for mammograms and MRI. Then I was talking about this one, CDH1. This is the one, and I talked already about this, in that it's very difficult to cancel because the recommendation is the removal of the stomach. And thank you. If you have any questions.
Thank you so much for coming on tonight. What I will do is I will open the floor if anybody has questions. If you want to raise your hands, or if you don't know where the raise your hand button is, you can feel free to just like physically raise your hand and we'll call on you.
And let me tell you something. So I discussed breast cancer, but if you notice in that graph, this is not only breast cancer, it's associated with multiple other cancers. And this is why we do panels. And this is why when somebody comes, they end up being testing. I have patients that come for colon cancer and then they test positive for increased risk for breast cancer, because these are mutations that even if you don't see in the family, can be in the family. But when somebody said, I will only want to test for the genes associated with breast cancer, I would say maybe there is only maybe one that we know. We don't have that. These are syndromes.
How many genes are out there for testing? Like when you test right now,
the biggest panel is 91 genes.
Okay.
And there is no difference in price. Or for example, if you come and you meet criteria for testing, the insurance pays for the insurance pay for BRCA1, BRCA2, maybe pay for PALB2, and then they will, the lab will add the other genes.
Perfect.
And if somebody has to pay out of pocket, it's $250.
Kathy?
Yes, I have a question. I am BRCA1 positive, and I have had both breast cancer and ovarian cancer. When I had my testing done, I had a single site analysis, and I'm wondering if there's any benefit for me to have full testing at this point. I mean, it's been a number of years.
Well, it depends a lot on your family. What is your family history? Do you have any other cancers in your family, like colon cancer, or do you have colon polyps?
I have had colon polyps, but they were not the precancerous kind, they said. So I have had them, and we have had colon cancer in our family. We've had pancreatic cancer. We've had...
Okay, so let me tell you something. If you were tested a long time ago, likely, so it was Myriad. At that time, that was the only lab. Myriad has a program, update testing, in which if you have genetic testing with them and you have other cancers in your family that cannot be explained with the mutation that you have, they do the update testing for free, and it's 35 gene panel. And that includes genes associated with colon cancer and pancreatic cancer. So it's possible that you qualify for that update testing. And definitely if you have family history of colon cancer and pancreatic, even though BRCA1 is associated with pancreatic cancer, the risk is very low. And there's other genes that are associated with pancreatic cancer that are very common too, like Lynch syndrome. Lynch syndrome is associated with colon, uterine, ovarian, other GI cancers. And that, I think that you should at least come to see us, and then we will check your family, and likely you will not need to pay for the test because of this update program. That answered your question?
Yes, it did.
Okay.
Thank you.
Did anybody else have any questions?
This is, yes, Tracy, Sophia.
Go ahead, Sophie. Welcome. How are you feeling tonight?
Yes. Let me. Hi.
Hello.
Okay, so with me, thank you so much for your presentation.
Right.
I have the BRCA2 gene mutation. I was diagnosed with breast cancer last November and had my double mastectomy done in February. And then last week, I actually had my tubes only removed. So they're giving me an option to reevaluate. I'm 43 years old, and to reevaluate for the ovaries, to have them removed either after I'm 45, but no later than 49. Just and I know that I already had the breast cancer, so am I risking it like by holding on until I'm 49, or?
Yeah, I consider yes. But let me ask you this question. Do you have any family history of ovarian cancer?
I don't.
No. Okay. So if we go by the guidelines, and I like to go by the guidelines, you can, so for the BRCA2 mutation, they said to remove at age 40. That's why, and you can wait until age 45 if you decide. 40 is the ideal, but you can wait until the age 45 because BRCA2 the ovarian cancer tend to happen after. But I don't know where they got that 49 because the guideline says 45. And the fallopian tube, the removal of the fallopian tube, there is this belief that the ovarian cancer is starting the fallopian tube. That is, there have been a lot of studies and they still not recommending that as an option for risk to reduce the risk. The recommendation is to remove the ovaries by age 45. I don't see anything wrong that you remove your fallopian tube. What I see wrong about the statement is to wait until the age 49. I will say I will go by the guidelines, which is 45. And so the reason the most difficult decision that somebody has to make with a BRCA mutation is when to remove the ovaries. I always say to the patients, in theory, the guidelines said age 35, and the rationale is good. So the rationale is if somebody removes the ovaries at the age of 35, then they can reduce the risk of ovarian cancer up to 50%. But it's still up to 50, they remove the risk for breast cancer up to 50%. But it's still, if you remove it by 50%, it's still a high risk. You still have to do mammograms and MRI and all that. The problem is that the ovaries are cardioprotective, they protect your bones, well-being. So what I usually recommend, and I will recommend this to you, is that yes, remove it by 45, but then you have a couple of years to do the best for your health. So you work out, exercise. Remember, because there's 7 years approximately of protection, cardioprotection, that you are not going to have because you're going to remove your ovaries. So be healthy. The cholesterol levels, try to make it right, try to lose weight, try to do everything to help your heart, because it's cardioprotective, but if somebody doesn't take care, you can still have issues. So I always say that to the patient, when I talk to 30-something, I said, you have plenty of time to do everything that you need to do and then for the bones, lift weight, doesn't have to be a lot, but weightlifting help. So all the things that you can do so you're ready at age 45 to do what is in guidelines, which is remove the ovaries at age 35.
Okay, thank you so much. I do take, they are prescribed, my oncologist prescribed tamoxifen, and I'm also estrogen and progesterone positive. But but thank you so much. I'm definitely gonna do that then. In 2 more years, I have. Yeah,
you have 2 more years to be the best. To have I'm doing that myself. I'm gonna be 50 and I'm exercising a lot because I'm for the long run. I'm not saying I want to lose 10 pounds. I said I want to
Yes.
be my best at the age of 50. So,
Okay.
you know, do that for the age of 45.
Thank you so much. Thank
You're
you.
welcome.
I've got a quick question.
Of course, go ahead.
Does your, so I'm BRCA1 and check 2. So with the combination of that, does your percentage, do you combine the percentage of risk of breast cancer, or
No.
it just, no?
No, this is a very good question. So you go with the highest risk. So the BRCA1 is the highest risk. So that is your risk. Your risk is like 70%. And you have a risk for a second breast cancer that we don't have in patients with check 2. So you get, so your risk of a second breast cancer is 40. You said that you have cancer, I'm sorry?
No, I don't, no.
Okay. So when you were talking about a surgery before we started.
Yeah, preventative, prophylactic.
Preventative, okay. Okay. So then, so your risk is the highest risk. You pick the highest risk, and this is BRCA. Then you have the highest risk for colon cancer, because in BRCA1, we don't have risk for colon cancer. So your risk for colon cancer is approximately 20%. So you're going to have colonoscopy every 5 years. Or we said every 5 years or earlier, depending on what are the findings in the colonoscopy. Then you go by that. You go by the highest risk. So I have had patients who have BRCA1 and BRCA2 mutations. So they get the risk for breast and ovarian cancer, which is higher for the BRCA1, but they get the other, the pancreatic, the melanoma, and the prostate cancer risk from the BRCA2. It doesn't sum up. So that doesn't mean that you have a 100% no.
So you said for check 2 is colon cancer. So I had my first colonoscopy at the age of 50, and they found a precancerous polyp. So at the time I didn't know I had check 2. So I'm actually 5 years is next August. Should I be going sooner than 5 years then?
No, 5 years will be fine. Okay. So for the colonoscopies, depending on what they found in the, how big was and how many polyps you have, so the size, the type, how difficult was to remove, that is taken into consideration to tell you when to come back again. If they say 5, then you go 5, but then if it's gonna be 5. So they told you 5 because once you have polyps, it's every 5 years. But now maybe it was associated with that check 2 mutation. And something that I didn't mention, and it's more for not for any of the participants. I don't know if there is a man in the group, but many of these genes are associated with prostate cancer. We know, and some of the genes that I mentioned, even if they're not say that associated with prostate cancer yet, we believe are going to be associated with prostate cancer. So basically what is going to, I'm foreseeing that all the genes associated with breast cancer are going to be associated with prostate cancer.
Can I ask one more? Sorry.
Sure.
So my mom tested years ago, and she didn't test positive for any of the mutations, but she did have breast cancer at age 58, and then I guess 10 years later she passed away from peritoneal cancer. Mm-hmm. So she didn't have the gene, but I know that the tests have come a long way since then. So I wasn't even told back then, not even to take the test, and I decided last year to take it. And I'm wondering if I should have my dad take it, because my sister also tested and she's positive for BRCA1 and PMS2, which I'm not familiar with.
I'll tell you what is PMS in a moment. So let me tell you about the situation with your mom. 10 years ago, they were doing only sequencing. So sequencing is like the spelling test of the gene. So if you have a deletion, it's possible that she carried the mutation, but they didn't identify it with the test they had at that moment. Okay, so or it's possible that she had the check too. So it's possible that that is the case. I will still recommend testing your father, because just for his benefit, but if he's older, is more for the benefit of that side of the family that you will recommend testing. PMS2 is Lynch syndrome, and but when you think about Lynch syndrome, if you Google Lynch syndrome, it's gonna give you like a lot of things, and really PMS2 is the milder. It's really the milder of all of them. So it's associated with an increased risk of colon cancer, higher than the risk that you have. And then colonoscopies in that case is every 1 to 2 years. It's not it's more because it's Lynch that they say 1 to 2 years, because other genes have the same risk and they say 5 years. But because it's Lynch and they want to have more information, they do it every 1 to 2 years. Also, it's associated with uterine cancer. So your sister should have the uterus removed. Well, they said, oh, screen, but, once you have children, how old is your sister?
She's 51. Yeah, so she's not having kids.
Yeah, but she's having menstrual period and then has a uterus that can develop cancer.
No, she's already gone through menopause.
Okay, so the recommendation would be to remove the uterus. The guidelines for Lynch syndrome changes and they don't commit. It's ridiculous. But the problem with the uterine cancer is the same. They will check and they will do biopsies, blind biopsy. So I will say, and you said your sister is positive for BRCA2? For
one, yeah. So she needs to get everything removed.
Yeah. So for BRCA1, you remove the ovaries, but there is a small risk for a uterine serous carcinoma. It's very low. So the recommendation is to talk to the doctor and the possibility of removing the uterus. For your sister, she has to remove everything.
Right.
Because she has a highest risk for uterine cancer because of the PMS2. But then why so many mutations in your family? It's crazy.
Yeah, I know. That's why I want to get my dad tested, although he's 80 years old and I feel bad to have him go tested. But he has a brother who has 3 kids and 2 of them are women. So,
If the problem is that if he has Medicare A and B, Medicare doesn't cover the test. Not even to come to see genetics. They don't even pay for the visit to see genetics.
Really?
Yeah. Wow. If he's part of like America or Humana, no problem. They don't pay for the test, but the majority of the labs offer the test for free because patients in Medicare are retired and they are in Social Security and nobody's a millionaire in Social Security. So when they do the calculation, the test is usually for free.
Is bladder cancer related to any gene mutation? Because he has bladder cancer.
It's associated, and they added recently to Lynch syndrome, but not with PMS2.
No, okay.
Not now, but this is changing all the time. The Lynch syndrome is always changing. So I'll say that. But he was a smoker. Was he a smoker?
Yeah, back in the 70s. Yeah.
Yeah, that's the number one cause of bladder cancer. But anyway, it will be good to know where the mutations came from. But if he doesn't want to have genetic testing, and that you can see that in some parents, they don't want the guilt of knowing that they carry a mutation. And which PMS, he would benefit with the colon cancer screening, but at the age of 80, many doctors, they don't recommend because it's too thin, the colon, and there is the issue with perforation. So it may not change much his care, but then I would still recommend genetic testing for your cousins. They will meet criteria. They don't need your father to be tested.
Yeah, no, I know.
They will meet criteria.
Okay, thanks so much.
You're welcome.
Does anybody else have any questions?
I just wanted to make one comment about the genetic testing because, I think Tracy knows my story, but I was diagnosed with breast cancer at 42, and my doctor for 10 years, my oncologist tried to get me to do genetic testing, and I wouldn't do it. and I was about to lose my mom to cancer, and my sister and I decided to do the testing. My sister went first because she had been 32 at her breast cancer. We tested with the positive with the BRCA1 mutation and decided to have the prophylactic surgery, and that's when they caught. We did not expect it, but when I went in to have my hysterectomy, a full hysterectomy, that they found that I had ovarian cancer. That's how we found it, was because I was doing my preventative surgery. And that's why I'm still here, because it was early enough. So
yeah, and that is when we talked to the patient, we said that it should be done by a gynecology oncology, because the person who is going to remove the ovaries, they should treat you as if you already had cancer. And the gynecology oncology has an extra training of being able to identify. So yeah, and there have been cases like that. Then I had a patient who had the diagnosis of breast cancer saved her ovaries, because when she had the ovaries removed, she has a very early stages, so she's doing very well. So yeah, so that's the benefit of doing this, and this is why we said that this is important to remove, and the guidelines are based on population database, so this is why the ages should be followed. Now again, you move 5 to 10 years, so for example, if somebody in the family of it's a Julio Martinez, but I don't know your name.
Sophia.
Sophia. So in the case of Sophia, if let's say I asked, when was your family history? So if she had a family history of ovarian cancer at age 50, even though the guidelines say 45, she could consider doing it at 40, because it's 5 to 10 years younger than the earliest of diagnosis. So it moves depending on family history.
And I also have a question, because I know I hear a lot that many remove your uterus and do a full hysterectomy. But for me, that was not even brought up. They told me, my oncologist said, your uterus is no harm to you. So, and then I'm thinking, I'm taking tamoxifen. I read, of course, you see a lot of information on Google, but I also read that tamoxifen can give you uterus cancer. And my oncologist said, no, that's not true.
No, it's true. It's true. It can. But yeah, but let me explain.
This is...
No. So the probably, okay, is associated with uterine cancer. So tamoxifen is associated with uterine cancer, but not at your age. So when they did the large study, they noticed that the people who developed uterine cancer were people older than 60. This is why when somebody's postmenopausal, they don't get tamoxifen, okay? So at your age, the possibility of developing uterine cancer is very low, but it's not that it's not associated, it is, but the probability is very low. So you don't have to remove your uterus because BRCA2 is not associated with uterine cancer. If it was BRCA1, there is a very, very, very minimum risk for uterine cancer, but there is the option of having the uterus removed. At the end, and what they do is somebody start bleeding a lot while in tamoxifen, they do transvaginal ultrasound. Now, at the end is a discussion between the gynecology oncology and you. You talk to the surgeon, you express, you ask, my risk, should I remove? And there is a discussion with the gynecology oncology and you. So the uterus is not the same as the ovaries. The ovaries has a purpose that follows you for many years. The uterus is for carrying babies, and when you're done, it's a discussion to have with the doctor. Especially if you want to be there in surgery, but it's not part of the guidelines to remove the uterus in BRCA2.
Okay. And tamoxifen is not a reason like that would give you endometriosis? That's more hormonal?
No, endometriosis we don't know what caused the endometriosis, to tell you the truth. There is
When they-
research going on.
When they removed one of my tubes, they did biopsy on both of my tubes, and one of them came back with tubal endometriosis, but it was microscopic, like 1 centimeter.
No problem. Yeah, no problem with that. Well, if you don't have pain,
No pain. No pain.
so that's, yeah, no problem. Yeah, no, it's not associated. And
Okay.
but again, is regarding the uterus, is a discussion to have with your doctor. Okay, but tamoxifen is very important. You don't stop taking tamoxifen, because tamoxifen is part of the deal with you. You have a cancer that like estrogen. You want to lower the amount of estrogen because you don't want to feed that cancer. And also it happens to reduce the risk for a second breast cancer. The tamoxifen is used for prevention too. So if you have somebody who has a high risk of breast cancer based on family history, you haven't found a mutation, you give tamoxifen if the risk of developing breast cancer in the next 5 years, when you do the calculation, is more than 1.7%. So raloxifene is for premenopausal women and raloxifene for postmenopausal women. So it's a safe medication. So that is something that you need to understand, because how are you going to give a medication to somebody who doesn't have cancer for prevention if it wasn't safe? It's safe, but if somebody, for example, let's go back to Kathy's sister. If she's taking tamoxifen, she needs to discuss that with her doctor, because, for example, there is an increased risk for uterine cancer already, okay? So that will be a good case to have the uterus removed. Then you can give tamoxifen, or you may not decide, but then, then you have to be careful. But again, the uterine cancer in tamoxifen in the study were from women older than 60.
Now, I have a question for tamoxifen. Once I remove my ovaries, will they still prescribe that, or will they switch me to a different medication?
No, you will continue with tamoxifen, because yes, the ovaries are the number one engine of estrogen, but you have estrogen in your fat tissue and in other parts. So yeah, you still have to take tamoxifen until it's usually 5 years, and then 5 years, but it's until your doctor say. He
said it could be 5 or 10. So,
yeah.
And I don't understand why after the 5 or the 10, you no longer need it. It doesn't make sense.
This is based on studies. They have done studies, and this is based on data. And it was 5 for some time, then they added 10, then they believe 7. So he said, when somebody says 5 to 10, is because even the doctor doesn't know what will be the information at that time. So yeah, they say some patients say, well, he told me 5 and now he said 10. Well, but it was because there were changes in the information.
Okay. Thank you.
You're welcome.
Thank you. So much information. Oh my goodness. Thank you.
Thank you, Dr. Martir, for coming on tonight. It was truly honoring to have you on and educate and learn more about all the genes. Several women all over the world, and hearing about all these genes and getting updated information is just so important for us as we continue to help other women throughout the world, and just updating each gene and the different criteria and when to get screened or who to screen. So I'm very thankful for your time and coming on tonight.
And this is, these guidelines change. So when we see a patient with a positive result, we usually follow the patients every year. Before, at the beginning, not everybody was here. I was discussing that the latest change in the guidelines in general for BRCA1, BRCA2, and many genes associated with breast cancer and pancreatic cancer is the addition of screening for pancreatic cancer when there is a first or a second degree family member, with endoscopic ultrasound alternated with MRI, MRCP. So this is something that you may want to look in your family and then discuss that with come to genetics, because the gastroenterologist maybe is not aware, because it's something new.
Thank you.
You're welcome.